All right, everyone. I'm Arseniy Yashkin, and I would like to welcome you to the afternoon session. And today we're going to talk about using Medicare and Medicare-based data for the analysis of disparities in Alzheimer's disease and related dementia. And we have three presenters for you today. And rather than take their wind and talking about their presentations, I would like to draw your attention to some common elements which will be present in all three. So today, all the presenters are using more than one source of data that describes the same underlying disease process, but also the functioning of the same underlying system. Which system is it? It's the Medicare-Medicaid system, otherwise known as something being operated by the Centers for Medicare and Medicaid Services, which isn't just Medicare and Medicaid data, it's also the minimum long-term care data set and other useful components that fit together in surprising ways. So the first presentation has to do with the minimum data set, but also an alternative supplementary source describing the same patient. And our presenter is Yulia Hyunkyung. Please.
Hello, I'm Yulia Hyunkyung, a PhD student at Brown, and I'm going to present about using electronic medical records of nursing home residents for improved measure of behavioral symptoms and the differential findings by resident race and ethnicity. First, I want to acknowledge my co-authors, Dr. Dinsmore and Dr. Ellen McCready from Brown School of Public Health. Also, I appreciate Dr. Susan Mitchell and Dinsmore, PIs of the Impact Laboratory, for their supervision and support. And I also want to thank you all for having me here. The presentation will be largely divided into two parts. First, I'm going to share the findings on the behaviors captured by EMR on top of the MDS. And second, I'm going to look into EMR detected behaviors by race and ethnicity groups. So at some point in the disease course, nearly half to 83% of persons living with Alzheimer's disease and related dementias will experience edited behaviors, such as pacing or yellow and usage. These symptoms may affect the quality and safety of life of not only those a person experiencing the behaviors, but also other residents or caregivers in the nursing home settings. And this behaviors can also contribute to burnout in nursing home staff. So it's important to accurately identify behaviors among residents with dementia or policymakers and researchers so that they can understand the size of the problem in the nursing homes and correctly examine the impact of behavioral management strategies. So interventions to reduce behavior problems are increasingly evaluated using embedded magnetic clinical trials, and is typically relying on routinely collected data in nursing homes, minimum data set MDS, to certain outcomes. However, there is a concern that MDS assessments significantly underestimate the prevalence of behaviors in nursing homes compared to both standard behavior assessment tools, such as CMAI. So structured or unstructured EMRs may lead to better identification of behaviors in nursing homes with ADRC for the evaluation of the pragmatic trials outcomes without additional data collection. So the first part of our study aimed to compare the prevalence of behaviors as measured by MDS only and as supplemented by structured and unstructured EMR data. So we used MDS assessment data and EMR data provided by a large corporation that covers from January 2020 through August 2022 for 32 months. Although limited, this multi-state corporation uses the most common nursing home EMR in the US, which is likely representative of a large proportion of US nursing homes. Our study population included long-stay nursing residents with ADRD, and ADRD status was defined based on the MDS checkboxes or their related outdated templates. So we compare the three agitation measures. First, MDS. Agitated behaviors identified by MDS were based on 4 types of behavioral symptoms and the past week, so 7 days. Physical behaviors toward others, verbal behaviors toward others, other behaviors not toward others, and rejection of needed care. So responses to these 4 measures were summed up to construct the agitated and reactive behavior scale, the ARBS, which ranges from 0 to 12. The proportion of residents with ARBS greater than 0 was considered the behaviors identified by MDS. Well, second, interact. This was the structured EMR data. Intervention to reduce acute care transfer is a suite of provider tools aimed at improving early detection of changes in behaviors among nursing residents. When fully adopted, it is likely associated with a decrease in potentially avoidable hospitalizations, and many nursing homes have integrated this tool into their EMR. We use the behavior data from Interact SEAR communication form, which is embedded in the nursing home EMR, and has 3 yes or no items documenting an increase in resident agitation, verbal aggression, or physical aggression. So the proportion of residents with any increase in behavior documented in their e-enter form was considered structured behaviors identified by structured EMR data. And third, physician orders, the unstructured EMR data part. We conducted keyword searches of these free-text physician orders, which document behaviors to justify one-to-one or increase the supervision, medication use, or restraints, or to request psychiatric consultation. The keyword search algorithm indicated orders based on 36 keywords, and the findings were manually reviewed. The proportion of residents with orders documented behaviors was considered the behaviors identified by unstructured EMR. For the analysis, we first identified nursing homes with ADRD, nursing residents with ADRD who had a routine MDS assessments in a given month, and then pulled all the interact forms and orders for those residents in a given month. And the analytic data were organized by curriculum. Means were used to report the prevalence of behaviors by sources. We also considered variation in the use of EMR for behavior factors across nursing homes. Then we assessed the overlap and independent behavioral reporting across the data sources. So now let me share all the findings. We identified 77,936 MDS assessments for 19,785 long-stay nursing home residents with dementia and 322 nursing homes. Overall, as you can see, the characteristics were consistent with the national population of people living in nursing homes. So this is the main figure of the first part. This shows the gains in the identified agitated behaviors using structured and unstructured EMR data versus MDS as monthly trends from throughout the study period. The blue line here represents the proportion of long-stay residents with ADRD who had behaviors documented in MDS in a given month. And the orange line shows the proportion of residents with behaviors identified by MDS plus the structured EMR. And the red line represents the proportion of residents with behaviors now identified by MDS plus both structured and unstructured EMR. Although there are variations in magnitude, MDS supplemented by the EMR data presented gains in behavior detection of the MDS identification consistently during this period. So this is a little bit busy, but I will walk you through it. On average, the percentage of residents with identified behaviors increased from 14.8% using MDS alone to 16.2% in the total sample using MDS and structured EMR data, representing a 9.5% relative increase, and to 18.6% adding the 2 EMR data to MDS. So this represents 25.7% relative increase in identified behaviors. Then we stratified the nursing homes into 2 groups based on the use of structured and unstructured EMR, moderate and high use groups to determine if gains in behavior detection by EMR were driven by variation in the use of these forms. I removed the footnotes about the threshold of a moderate and high use phrase here since the slide was too busy, but briefly speaking, moderate interactive use nursing homes were those with at least 50% of residents in the facility had any indirect record. And high use nursing homes were those with the threshold of 75%. The thresholds were arbitrary because we tried to include over 90% of nursing homes in the moderate group and about 50% of nursing homes in the high use group, and similar for the orders. Similar to the findings for the total samples, EMR increased the average detection of behaviors, but the increase, the magnitude was larger in the nursing homes with high use of EMR. For example, in nursing homes with moderate use of e-interact forms, which is structured EMR data, supplementing MDS with 2 EMR data resulted in a relative increase of 25%. And compared to the MDS alone, it showed a relative increase of 25%. And the relative increase was 28.4% in nursing homes with high use of the indirect forms. Then we chose 1 month of the data to examine the overlap in behavioral identification across data sources. There was less than 1% overlap across any 2 sources, and only 0.2% had behaviors recorded in all 3 sources. When we looked at the behaviors identified by e-interact orders in a given nursing homes, the average proportions of eligible person month with behaviors within nursing homes were inconsistent across nursing homes, showing the variations in the use of EMR to capture behaviors. So from this first part, we found that using structured EMR in addition to the MDS resulted in about 10% relative increase in behavior identification compared to what was detected by MDS alone. And using the structured and unstructured EMR in combination with the MDS resulted in a relative risk of about 26%. Interestingly, there was not much overlap in behavioral detection across data sources. And this suggests these sources may be measuring different types of behaviors. In fact, the goal of structured EMR, e-interact, is to communicate a problem to the medical director and elicit a response. So it focuses on an acute change in condition in terms of behaviors. And whereas the goal of the unstructured EMR, the physician orders, is to justify ongoing medication use or request additional services such as consultation with a doctor or transfer to a hospital. So it may represent more severe or currently medically managed behaviors. The MDS behavioral items are completed for all residents, as you know. So it is independent of severity and documentation is not relative to a change in condition. So interventions to reduce behaviors among residents should be carefully targeted to the type of behaviors that researchers are interested in modifying, and the behavioral measures should be chosen following the intent of the intervention. For example, evidence suggests that verbal and physically non-aggressive behaviors are the most affected by the non-pharmacological interventions applied in the programmatic trials in a nursing home setting, and these behaviors may be better captured with routine data sources such as MDS. On the other hand, aggressive or disruptive behaviors may be important targets from a policy perspective, and they're better captured through the e-interact forms or orders or using newer built-in MDS. Also, an important part, we need to carefully think about how to ethically use this data to understand whose outcomes are represented and who is systematically missing. And this motivated us to look into any differential patterns and the behavior detection of EMR sources by race and ethnicity groups. And that is the next part of this presentation. So in our second part, named this, our key question for this part was, is there evidence of racial disparities in behavior detection by EMR data? And this can be examined, for example, by investigating whether there are differential gains in behavior detection by EMR data, and by investigating whether there are differential patterns in documentation of EMR or behavior. To answer these questions, we first tried to make a level playing field. And what I mean by that is that we wanted to isolate the influence that the level of general use of EMR data on their behavioral detection by racial groups, because there could be differences in behavior captured by EMR, not due to race and ethnicity groups, but due to the level of EMR use in general. For this, we decided to focus on nursing homes that are regularly using EMR. So we assessed whether there are differences in residents in nursing home characteristics between the total sample and the regularly EMR using nursing homes, because we didn't want our regularly EMR using nursing homes to be biased. So we compared the residents and nursing home characteristics between the total sample and the nursing homes that are regularly using EMR. And we defined the regularly EMR using nursing homes as those in the top quartile of the distribution of the average percentage residents with any interactive records within the facility throughout the study period. So not the interactive use for behaviors, but any records in the interact were measured as an indicator for general use of EMR. Resident characteristics were taken from the latest MDS record of the individuals and the facilities during the study period. And before going through the findings, I want to mention that here in our slide, in our analysis, we followed the MDS categorization for the race and ethnic groups. These 6 categories were from section 8000 from MDS dataset, and each of them combines race and ethnicity into one. So this may under-identify or not even identify the diversity among the population. And I know that there is a plan that the MDS race and ethnicity coding system will change by separating the two and allowing more racial and ethnic groups. But for now, this version in our analysis data use the current categorization. I just wanted to mention that. Black residents, as you can see here, were slightly more likely, and Hispanic and Latinx and Asians, those residents were slightly less likely to be in the nursing homes that are regularly using EMR data, although it did not differ much between the two groups. And they also showed similar levels of clinical conditions, medications, and functional skills. And there was not much difference in nursing home characteristics between the two groups. So overall, we concluded that restricting our further analysis to the regularly EMR using nursing homes to understand any pattern of racial disparities related to the EMR behavior detection would not significantly bias our findings to read the key dynamics. However, if you are interested in understanding behavioral outcomes of Hispanic and Latinx and Asian residents, minoritized populations which are already underrepresented in these data, considering only nursing homes which are regularly using the EMR data may bias results. Also note that we had to exclude the Native Hawaiian or other Pacific Islander group due to the small number of observations which were less than 10. Now, as a second step, we wanted to answer the question, okay, then do the EMR sources capture the behaviors consistently across race and ethnicity groups among those regularly EMR using nursing homes? In other words, we examined whether the gains in behavior detection by the two EMR sources differ by race and ethnicity. To answer this question, we first conducted an unadjusted comparison. Before comparing EMR detected behaviors directly, we looked at the distribution of moderate and severe cognitive impairment using the CFS scores by race and ethnicity groups so that we could compare the distribution of the EMR documented behaviors by race and ethnicity groups to this distribution. We expected to see for similar distributions in the EMR documented behaviors with the distributions of moderate to severe cognitive impairment, since the people with more impaired cognitive ability would be more likely to exhibit agitated behaviors compared to those who have intact cognitive ability. And it would be consistently reflected in the behavior identification. As you can see here, the white group shows the lowest level of moderate and severe cognitive impairment of 60% among all the race and ethnicity groups, meaning that the minoritized groups show a higher risk of cognitive impairment in our sample. Antipsychotic use did not consistently reflect the distribution of moderate or severe cognitive impairment, since, for example, white residents had higher antipsychotic use than Black residents, while Blacks had a higher percentage of moderate or severe cognitive impairment than whites. Hispanics, on the other hand, had higher moderate to severe cognitive impairment and the highest antipsychotic use. Asians showed the highest percentage of moderate or severe cognitive impairment, but a much lower antipsychotic use. And now look at the bottom. This is MDS detected behaviors. They were inconsistent with the CFS score. Whites show a higher percentage of MDS documented behaviors than all of the rest of the race and ethnicity groups. Despite the higher cognitive risk, much lower antipsychotic use, except for Hispanic and Latinx, and much lower MDS documented behaviors were observed among the minoritized population compared to white residents. Now, we also see the additional differences in the EMR data. We found that the adjusted distributions of unadjusted distributions of behaviors documented by different EMR sources do not coincide with the moderate or severe cognitive impairment either. In all three sources, MDS, eInteract, and Borders, Blacks and Asians show the lowest percentage of behaviors, while they had higher percentages of moderate and severe cognitive impairment than whites. And the sizes of gains by EMR and behavior detection over MDS among Blacks and Asians were also much smaller than those among whites. So from the unadjusted comparisons, racial minority groups gain less than the white group in the EMR behavior identification. So in summary, the answer to the second question of whether the sources equally capture additional behaviors across race and ethnicity groups would be no from this unadjusted comparison. There are differential gains in the EMR detected behaviors between race and ethnicity groups. The MDS and EMR data likely underdetect behaviors for Black and Asian residents compared to white residents, and this may be less true for Hispanic and Latinx residents. Then next, we further ask the question of whether the findings would change in the adjusted comparison. So far, we looked at the unadjusted comparison. So what if we control for the key factors such as cognitive and physical functional skills, clinical conditions and medications, demographic characteristics, and nursing home characteristics? Would we see changes in these differences in EMR behavior detection? That was our last question. So we adjusted for the aforementioned factors and time variant facility characteristics, including nursing home and earphones, fixed effects, and examined the association between the EMR documented behaviors and race and ethnicity groups. Here, I only display the coefficient for the race groups. We now see no significant difference in eInteract behavior detection between racial groups, and only see significant negative associations for American Indian and Alaska Native, and Native Hawaiian or other Pacific Islanders, and Borders behavior detection. Note that Native Hawaiian group has very few observations. It was 8. In both models, CFS scores were significantly positively related to the EMR behavior detection, even though I didn't display the coefficient here. And this tells us that, for example, among the residents who had the same cognitive level, there are no differential associations with the EMR behavior detection by racial groups. using whites as the reference group. Based on the result, it looks like the disparities disappeared. However, for that conclusion to be valid, we may want to confirm that the predictors we used in that adjusted models are equally important predictors for EMR behavior detection in all race and ethnicity groups, right? So lastly, we conducted another analysis to better understand the dynamics of how the key indicators interact with each race group in the context of EMR behavior detection. Because we saw from the unadjusted comparison that there were inconsistent or opposite relationships between cognitive impairment scores and EMR behavior detection. So our last question was, do the key indicators, the cognitive impairment scale and the antipsychotic use, play a key role in the EMR behavior detection in all race and ethnicity groups? If so, the adjusted model well controlled for the similarly affecting confounders for each race and ethnicity groups, and therefore we could conclude that there may be differences in the distributions of the cognitive impairment levels and medication uses between race and ethnicity groups, and that just made the differential EMR behavior detection pronounced. And in fact, not that there were disparities in EMR behavior detection. So we examined whether cognitive impairment and psychotropic medication uses are similarly associated with EMR behavior detection separately by race and ethnicity groups. It turned out that moderate or severe sample scores were strong predictors for the EMR behavior identification for whites only, not for Blacks, Hispanics, or Asians. Medications, including antipsychotic use, were also differentially associated with the indirect behavior detection between race and ethnicity groups. The similar patterns in CFS scores were observed in the order behavior detection. In summary, the predictor cognitive impairment levels that we thought would be key indicators for EMR behavior detection were so only among whites, not among other groups. Antipsychotic use was significantly associated with EMR behavior detection among all but Blacks and Asians for the indirect, or only with American Indian or Alaska Native, but negatively for the older behaviors. This means that the adjustment we made may not be an appropriate one. This also means that the conclusions made based on this traditional way of adjustment to understand the outcomes using the EMR may not be accurate and even biased in their understanding of differential dynamics and the minoritized race and ethnicity populations. In conclusion, we found that there are differential gains in EMR detected behaviors between race and ethnicity groups among regularly EMR users. Also, the behaviors captured by EMR data do not consistently align with the other key indicators across race and ethnicity groups. Cognitive impairment was strongly positively correlated to behaviors that are captured by EMR sources among white residents, but it was not among other race and ethnicity groups. So it is an important next step to understand what leads to this result and whether it is so in other EMR data as well, because we use the one population. It might be worth investigating whether there are differential practice patterns by staff in EMR documentation between race and ethnicity groups in nursing homes and what factors would play a role here. For instance, is it racial concordance between staff and the residents? Or is there any other socioeconomic factors? It is an unknown area what the drivers of these differential gains in behaviors captured by EMR sources are, and it requires further research. It would be appropriate to use the data for future health disparities research based on a clear understanding of these dynamics lying in the EMR data. And these are some limitations, including the one that I said, we follow the MDS race and ethnicity categorization practice, which may increase the accuracy of the analysis. So in conclusion, the use of structured and unstructured EMR data, in addition to the MDS, could augment the detection of agitated behaviors overall. However, the gains achieved by these EMR sources in behavior detection do not look consistent across race and ethnicity groups, and further analysis is warranted to investigate the mechanism of the observed patterns. And our findings also have implications for better targeting and evaluating the effect of behavior management strategies. With this, I would like to end my presentation and thank you for your attention.
So when I looked at this presentation, the first thing that came to mind was a very familiar page. So y'all remember we had that green line in the graph. We had MPF data only. We had MPF a little bit higher, supplemented by additional records, and then we had the red line. Now, what came to the forefront of my mind is that these are administrative processes, right? So to try to figure out what's going on, it makes sense to think of an administrator, well, what am I filling out and why? So the MDS is a quarterly exam, usually. You get one at admission every quarter, at discharge, and there's a hint, and whenever something happens, right? And then there's an extra trigger for MDS evaluations, depending on who paid for your stay. If it's a short-term stay, usually that's going to be Medicare. If it's a long-term stay, usually that's going to be either you or the Medicaid system. What are the additional rules imposed by the payer? So one way to get that MDS only line up may be to extend your look-back period from a month to a couple of quarters, because bad behavior may have been bad behavior, right? The behavior we're looking for, right? It may have been documented on last quarter's evaluation or some other time. There may be an administrative lag, whereas the supplementary record, what's the logic? I need to solve a problem right now. I need some medication for this person, right? And I need a reason. So here's the reason. I remember a couple of times ago something happened. Here's the reason for this medication right now. So the administrative process itself puts in very predictable types of bias. So we can't say it's not predictable because it is. It's moved by the logic of the administration, right? If you know how the administration works, you can go and take a look and look for administrative issues in your data. Now, this presentation also drew attention to bias. What happens if we exclude people from our analysis? And this is also in part what the next presentation is going to be about.